Hello, everyone. I'm Lisa Clary Lawler. I'm one of the co-chairs of this year's event, and this is the 7th annual Women+Wellness, and thank you all so much for coming. I'd like to first thank all of our incredibly generous and long-standing sponsors. They make this event possible, free of charge to the community, and we also were able to raise some additional funds for the hospital, which is always a great goal. I also like to acknowledge and thank our event founders, Janine Borthwick and Meryl Bralauer. We're right here. And Melanie Sablehouse, who unfortunately is not here, but we have her daughter-in-law to be here, so that's great. Also would be remiss in not thanking this tireless development team that puts together not only this event, but so many others. So please, a round of applause for them, because they really have so much on their plates right now. And also to our fabulous staff here at Great Harbor, who make this event possible as well. So thank you. So many of you have asked, how did we select this topic of myth-busting your way through menopause and other tips for managing through women's reproductive health? So I think last year we talked about the fact that we have in the past, we've surveyed attendees and always welcome any thoughts that people have in terms of sharing their ideas. So it really does help inform what our programming is. But back in 2023 in February, there was a very powerful article in the New York Times, and it really kind of sparked a movement about menopause. And there's been a lot of articles since, New York Times, Forbes, and actually a lot of industry that's been capitalizing on this moment in time as well. And so that started the conversation that we had. We think there's a lot of energy around this topic, but we think that it's a longer conversation. It's about sort of this journey of women's reproductive health and how do we get women understanding and talking about this earlier. And so that really had a huge part in our deciding who we wanted to have speak. So that's my fourth area of gratitude, is to Amy Lee and to my co-chair, Heather O'Sullivan, who unfortunately is not with us today. She had a family commitment, a happy one. And they suggested Dr. York Best, Dr. Carey, and she is known to them personally and professionally. She's their doctor, and they were so effusive about how amazing and warm and knowledgeable and what an expert she was. So that just seemed like it was just meant to be. So let me tell you a little bit about Dr. York Best. She's been an attending physician at Mass General Hospital since 1993. She and her husband are both OBGYNs, which is kind of a fun fact. But back to her. Dr. York Best specializes in, she provides specialized gynecological care for abnormal conditions such as bleeding fibroids, ovarian cysts, and endometriosis. And she also has expertise in minimally invasive gynecological surgery, perimenopause, and the gynecological care of breast cancer patients, which is a really unique and I think a very relevant topic for a lot of people, and hopefully not too many here. She is also an active teacher in the MGB OBGY and residency program. And you're going to be hearing from another one of our doctors later on who actually trained under her, and they're very good friends, and they're still very much partners in the medical field. So that's just very fortuitous that we have both of them here today. So let me get back to some more fun facts about Dr. York Best. Her father was an international businessman, and she was raised in England, which you will definitely hear with her beautiful, lovely accent. And during her first 2 years of high school, her family moved to Brazil. And then 2 years later, they moved to Wilmington, Delaware, and I would imagine that was a bit of a culture shock. So my father was in the military. When we had an overseas assignment, I had 3 high schools, so I appreciate that. It's not an easy time for anybody, much less overseas than back in the States. She attended Harvard not once, not twice, but 3 times for her undergrad, her medical school, and also her residency. She lives in Concord, and as I mentioned, her husband, Dr. Craig Best, is also an OBGYN, and they have 3 adult children in their 20s. One of my favorite things about Dr. York Best is that she is a leap year baby, and she just celebrated her 15th real birthday, which is awesome. So Dr. York's extensive experience is a perfect fit to lead today's discussion on myth-busting your way through menopause and tips for managing through women's reproductive health. I am honored to introduce this year's keynote, who I call the Dr. Ruth of menopause, Dr. Carey York-Best. Please welcome her to the stage.
Thank you so much for those wonderful, beautiful comments. And thank you for welcoming me to the island. I've had a wonderful weekend. It's just so beautiful here. I haven't been here for many years. And so great to see the community that you have here on Nantucket. I've given this talk on menopause, or a version of it, many times to medical students, residents. This is the first time, I think, to a community of women, but I'm really excited, and I've never had such a good PR team behind me coming up with a great title for my talk, Myth Busting Your Way Through Menopause. Usually I have a much more sedate talk. As with all talks, I just have to say I have no disclosures to make. And you're right, Lisa, this is exactly what I was thinking about when we was getting ready to do this talk, that there's really been a bit of a renaissance about menopause in the past year. And I think a lot of it did come from Susan Dominicus's article in the New York Times, where she really outlined all the uncomfortable and very disruptive symptoms that women have during menopause. And she really admonished the medical community for not taking these seriously, undertreating women, and furthermore, not really training the new generation of medical providers in menopause. So we're trying to make sure that all our new providers get very well versed in this. Even more recently, like in the past couple of months, I suddenly noticed I was getting these phone calls from long-term patients of mine who I've seen year in and year out, and have been in menopause for a few years, and they called me like, can I come and see you? I just heard menopause hormones are safe and they're really good for you, and I don't want to miss out on anything. I don't want to hear it's too late and I should have been on the hormones. And I think I was like, have I missed something? Did I get behind on the literature? So of course I Googled like everybody else does. And I realized that this is really the article that came out in May that Joanne Manson wrote. She's the major researcher that sponsored the Women's Health Initiative. And not to go to the punchline, there's not new data, but there is new news, I guess, how it's interpreted. But we'll get to that. So today, my goals are to sort of go through a little bit of the terminology of menopause transition, and to look at some of the physiologic changes and symptoms that women have in menopause, talk about the role of ovarian hormones and long-term health, talk about the risks and benefits of hormone replacement therapy, and also other options we have, and then to sort of think about how we can best devise an individualized risk-based strategy for treatment of menopause symptoms for each individual patient that we see. So first, I'm going to my terminology, and in 2012, the Endocrine Society actually had a whole conference to define the stages of women's reproductive life. And of course, we're focusing today on this particular portion of it, the menopause transition, and then that very first year of postmenopause. So menopause, by definition, is a year after you've had your last menstrual period. So it can only be made in retrospective diagnosis. So it is a time where there's many, many hormonal changes, especially in this couple of years, which can range anywhere from 1 to 10 years of perimenopause leading up to menopause itself. And then also in the first year of menopause, there's a lot of hormonal changes, a lot of physiologic changes that women go through. Menopause average age is 51. Average age for a woman's lifespan in the US is 81. So women are spending more than 30 years of their life in menopause. I'm very proud of this slide. John Schifrin, who is a big guru, told me, can I take that slide and put it in my talk? So this emphasizes the tumultuous hormonal changes that happen to women in perimenopause. So prior to menopause, each month when you have your period, there's this very rhythmic rise and fall in the estrogen levels. They range between similar levels each month. In perimenopause, basically hell breaks loose. And I think the red line is your estrogen level. And I think it's really telling how it completely mirrors the roller coaster on the other side. And I don't need to tell women who've gone through it that that's how it feels, because it really does. What I do like to try to encourage my patients to believe in is that after menopause, the postmenopausal timeframe is a timeframe of a new hormonal equilibrium, kind of like these nice straight train tracks going through a pastoral setting. So menopause transition, there are just so many symptoms that can happen around this time. Most of symptoms are symptoms that women and men are very familiar with. It ranges from the classic hot flashes, the vaginal dryness, the pain with intercourse, and then all the hormonal disruptions around the menstrual cycle, heavy bleeding, not bleeding, never knowing when you're going to bleed. And then also there's other symptoms like depression, mood changes, insomnia, headache, weight gain. It's really fun. So rather than just trying to think of menopause as this plethora of really unpleasant symptoms that we all have to deal with, we want to try and think of it as a time where you can sort of really optimize your health and think about the long term, how you want to live the rest of your life in that lovely straight line train tracks portion. So what are hot flashes? I would say the first myth I want to bust is that they're nice. They're like a nice warm flush that you have on a cold night. No, they're not nice. They come at very inconvenient times. They wake you up multiple times at night, drench the bed sheets. Patients have to change their pajamas all the time. I mean, this is really disruptive. And also, it often comes with this sense of impending doom. So just looking at my nice little picture for my title there, I Googled hellfire. 80% of women have hot flashes. Some don't. The median duration is about 7 years, and that can be anywhere in that whole perimenopause to postmenopausal timeframe. They actually have found there's 4 different genetic variations of how women have hot flashes. I think it's kind of like morning sickness. Some people have it, some people don't. We don't really know why. Everybody's hormonal changes are the same. But there is, unfortunately, women who continue to have persistent, uncomfortable hot flashes for 20 years after menopause. Up to 10% of women still are suffering hot flashes at that time. How do we treat hot flashes? Well, we talk about lifestyle modifications, avoiding triggers like alcohol and coffee. How can you function without coffee? We talk about trying to keep your weight down, doing cognitive behavioral therapy. There are lots of supplements out there to help with menopause. And you can buy them anywhere online. You can Google it. They all work. They reduce hot flashes by 10%. So does placebo. So I tell my patients that. I'm like, they work as well as placebo, even when I tell you that they're a placebo. They just cost a lot of money. So I would be very, very leery of marketing ploys. I'm not against it. Sometimes it really does make a difference. It just helps to know that you're doing something. But as I say, placebos work well too. We have medications that can be really quite helpful. Some of the neuromodulators, Neurontin, especially women with breast cancer who can't use any hormone therapy, will often use Neurontin, and that can be a lifesaver for many women. SSRIs, Bristol is one other. Paxil is the other name for it. It's marketed as a product for menopause treatment. Venlafaxine. There's a new kid on the block. I still can't quite really say it. Tiffany, fezolinetant. I don't know, I'm having a little trouble with that. Vezoa is the brand name. It is the first targeted therapy looking at the thermoregulatory center in the brain. So it actually works to prevent hot flashes. And it's very promising. It's 60% reduction in hot flashes, doesn't have other hormonal components to it. So we're excited about that. Right now, it's hard to write a prescription for that for a patient. It's hard to get it covered. It doesn't seem to be really covered by most insurances. So it will be another year or so probably before we can realistically use it. But it's great that they have this new medication. And then, of course, we've got hormone replacement therapy, which is terrific. It works really well to treat hot flashes. I want to address just a couple more symptoms of menopause because this comes up all the time when I'm talking to my patients. Does menopause cause depression? We don't really know actually if it does. There's some areas, some studies that suggest like a 2 to 4 times increase in the risk of depression. I think at the very least, we think of it as sort of a time of vulnerability, kind of like adolescence and postpartum, where there's huge, often socioeconomic and psychosocial stresses going on, and also major hormonal changes. And it is important that we manage depressive and anxiety symptoms that happen during menopause. Estrogen alone isn't very good at treating those symptoms, but estrogen can be a good adjunct. So we definitely encourage, seeking mental health care providers and getting started on antidepressants if needed, even if it's just for a transition of time. But estrogen can sometimes be helpful too. Other fun things, weight gain. I don't know why I hark on that because I really don't have a great solution to it, except to say that it's very common in midlife. We don't actually necessarily think it's got a lot to do with the hormonal changes of menopause. It's more to do with sort of the loss of your autoregulatory control of your appetite and just generally not moving as much as when we were younger. But obviously that's happening at the same time as menopause. Again, unfortunately, estrogen isn't going to fix weight gain in menopause. Osteoporosis is a big issue for women. We definitely encourage women to take calcium and vitamin D. Hormone therapy, again, is great at preventing osteoporosis. However, the minute you stop it, there's a very rapid loss in bone density. I just put sarcopenia up here because I think it's been helpful for me personally to think about this, that as you get older, you lose some of your muscle mass, have an increased fat to muscle ratio. So I think thinking about trying to maintain your strength and use your muscles and really, it helps with the bones, but it also helps keep your metabolic rate a little down. Obviously, exercise is very helpful for that too. So then we're going to talk about some of the cardiovascular risks that develop in menopause. The American Heart Association came out with a lovely summary statement where they specifically looked at some of the changes that happen with menopause, an increase in total cholesterol, LDH, triglycerides, apolipoprotein. They can see there's increased thickening of your carotid vessels and vascular stiffness. There's an increase in body fat, as I mentioned, and specifically of visceral body fat, the fat around the intestines, and that specifically is associated with cardiovascular risk. And there's also a very significant increased risk of insulin resistance in perimenopause as well. So hormones can be helpful with some of these things, and we're going to touch on, how hormones affect cardiovascular health, but also lifestyle, again, diet, exercise can blunt many of the effects that happen with the hormonal changes in menopause. Genitus urinary syndrome of menopause, that's what the terminology we use now for vaginal dryness. This is ubiquitous. Like it is, I feel like they should be giving vaginal estrogen out without prescriptions in the pharmacies. It's pretty much everybody. I often will look at a patient, I'm like, I'll diagnose your menopause by taking a little look, doing the pap smear, because you can see immediately all the changes in the vagina that happen when estrogen level is low. So it's not just dryness, it's severe, often pain with sex, difficulty with holding your urine, urgency, frequency of urination. So vaginal estrogen is a great thing, and pretty much anyone can use it. It's very safe. The one group of patients, unfortunately, that it's still somewhat contraindicated for, but often the oncologist will help us, will let patients use low doses of it. It's just patients with breast cancer who are on aromatase inhibitors, which drop your estrogens really, really low, and that's how they work to prevent the breast cancer. Talking just about natural menopause timing, it's definitely been shown that if you have a later age of menopause, you have a lower bone fracture rate, lower coronary artery disease, and lower all-cause mortality. And women who go through a very premature menopause before age 40, which is about 1% of women, they've shown that not only do they have the classic symptoms that we've talked about, the hot flashes, genitourinary symptoms, bone fracture, depression, diabetes, cognitive decline, and increased cardiovascular disease. Since I do surgery, obviously we're thinking a lot about the impact of doing surgery, removing women's ovaries. So the Nurses' Health Study actually looked at women who had hysterectomies, whether they had ovaries removed or not, and found that even though women who had their ovaries removed, which actually that's a typo, it's age 46 was the average age, they did have a lower risk of ovarian cancer and breast cancer, but despite that, they had a higher rate of death, largely because of the impact on cardiovascular disease and heart attacks. So what is hormone replacement therapy? I'm sure many of you know this, but when a woman has a uterus, we have to use estrogen and progesterone. We can't just give estrogen because otherwise you'll get uterine cancer, like 8 times the rate. So we always have to give both if you have a uterus. If you've not had a uterus, you've seen me, had your hysterectomy, then you can be on estrogen only. Estrogen's the good guy here. Estrogen is responsible for most of the benefits that happen with hormone replacement therapy. It comes in multiple different forms: patches, gels, rings, tablets. Progesterones only really come as combined patches or pills. You know, people often buy like progesterone creams that they rub on. You can't absorb progesterone through the skin. So that's one of those things that be careful if you got convinced to buy that online to help with menopause symptoms. It will help as well as a placebo, but it's not going to be absorbed by the skin. Prempro was the classic hormone replacement therapy that was used in the 90s and 2000s. Nowadays, we tend to use estradiol and micronized progesterone, which are the same hormones that your body makes before menopause. Yes, they're manufactured commercially, but they are actually the exact same chemical structure. So again, that's why many of us are a little skeptical about custom-made bioidentical hormones, because we can sort of reproduce the same hormonal compounds and use FDA-approved drugs where the dosages are very well regulated. So this was the article that came out in May. This is sort of review article that came out in JAMA, which again really just reviewed all of the things that we knew about the Women's Health Initiative. And it was by the primary author, Joanne Manson, who ran the study. And she did have a take-home message, which I'm going to write here, at the end of this article, or the article was very much talking about some of the longer-term benefits of hormone therapy that came out in the younger age group. So just for those of you who maybe aren't familiar with this study, the Women's Health Initiative was a huge study that was done in the late 1990s, early 2000s, where they had 27,000 women that they put into trials of using hormone therapy versus not using hormone therapy. And they had women of all different ages across the menopause spectrum, from women at the beginning of menopause in their 50s to women in their 60s and later. So and this study was done because there was a lot of epidemiologic data that suggested that estrogen and hormone therapy was wonderful, that it protected women's hearts, that they would live longer if they took hormone therapy. And I mean, I was a doctor in the 1990s. I was writing loads of prescriptions for Prempro and advocating to women that they started it. So we all thought it was really helpful for women, certainly very helpful for symptoms. But this study was done really to look and really try and figure out, did it really help heart disease? Or did it cause breast cancer? And it was a randomized control study. So basically, it had to be stopped early, because what they found was, instead of lowering the risk of heart attacks, in women who take estrogen and progesterone, it actually increased the risk of heart attacks, and it also increased the risk of breast cancer. The estrogen-only arm of the study didn't show such a strong risk about heart attacks, but it certainly didn't show any benefit. And both groups showed an increased risk of stroke and blood clots. So it really did. This is the reason that hormone therapy kind of fell out of vogue. So in the most recent updated article that Dr. Manson published, as well as many other articles that have come out in the past few years, they've really been able to specify looking at the younger age group. So these are the women who are just beginning to go through menopause in their 50s, mostly the women who have the worst symptoms and really are in need of treatment. So looking at these women who took hormone replacement therapy, initially at the end of the study, it did still look, as I say, even in this younger age group, like there might be a higher risk of heart attack. But after they followed these women for 13 years and they've looked again at the 20-year mark, they've actually found that not only is there no increased risk in cardiovascular disease, in women taking estrogen and progesterone, there's actually a very good benefit in terms of 50% reduction in cardiovascular death. That's a big difference. So there's been other studies that have backed that up too, with sort of very, very similar numbers. The estrogen-only group, as I say, was very neutral around whether it increased or decreased cardiovascular death, and in later studies has actually shown some benefits. However, there's a plus and a minus to everything. So breast cancer in the Women's Health Initiative in all age groups, including the younger age groups, was definitely a higher incidence of breast cancer. And again, it went up by about 25%, which is the equivalent of one more case of breast cancer per 10,000 women years taking hormone therapy. So the Women's Health Initiative had an unusual finding, which was women who only took estrogen actually had a lower risk of breast cancer, which is hard to put together with all the other things we know about breast cancer and estrogen. Estrogen is very, very much a cause of most forms of breast cancer, and most breast cancer therapy is really directed against reducing estrogens or blocking estrogens. And I think that we all need to think about the Women's Health Initiative with a bit of a grain of salt, because if you look at the much, much larger European worldwide studies that were done from the collaborative group, they did show that even women on estrogen-only hormone therapy did have a higher rate of breast cancer. And the longer they were on it, the more rapidly the breast cancer rate went up. So this is for women on estrogen and progesterone. So this is the rate of breast cancer incidence that goes up with age. With 5 years of use, it goes up, and with 10 years of use, it goes up more steeply. This is the estrogen-only group. It's about the equivalent, actually, of an increased risk of breast cancer if you have obesity. This is my last graphy kind of slide, and I'm hoping it makes sense to people. This is actually a slide that is showing the benefits and the risks of hormone replacement therapy. This is directly actually from the Women's Health Initiative, and this is the original data. So looking at the estrogen-only trial, red is bad, blue is good. So I like to start there. So when you look at the numbers at each column, this tells us the extra number of cases per 10,000 women that happened because women used estrogen-only hormone therapy. So there was a higher chance. 5 more women got blood clots, 3 more women had pulmonary embolism, but there was 11 less women had coronary artery disease. 5 less women had breast cancer, which we're taking with a bit of a grain of salt because I don't know if that's really true. But that's what the study showed. Fractures were decreased. Diabetes was decreased a lot. And all-cause mortality. So 11 less women died because they took hormone therapy. And this is estrogen therapy for 7 years. This isn't estrogen therapy for the rest of your life. On the combined estrogen and progesterone group, there's more red. Again, deep blood clots, pulmonary embolism, coronary artery disease was increased, stroke was increased. and breast cancer was increased. But again, very big protection against fractures, very big protection against diabetes, and all-cause mortality was still good, better in the women who took the hormones. And then, as I just was sort of outlining, this cardiovascular risk, the increased risk of heart disease in the women taking combined therapy, when you followed that group 13 years, 20 years out from when they took hormone, that increased cardiovascular risk went down. So it went back to normal, basically. So how do we put all this together? So the North American Menopause Society, which is a very good source, if you want to read up about, scientific data about menopause, go to the North American Medical Society. Menopause.org actually is the website, and you will really get to see the most updated data that we have for menopause. So, and this is exactly actually the same statement in a way that came out with Joanne Manson's most recent article in May. So it's not that hormones are necessarily good for you, although they do have a lot of benefits. Hormones are really an excellent treatment for the hot flashes of menopause. They're the best treatment we have, and they do reduce bone loss and fracture, and they do address the vaginal symptoms of menopause. So women who are suffering from menopause hot flashes, especially early in menopause, this is a good option for treatment, and especially in the women who are aged younger than 60 years. So we always say that first decade of menopause, and have been in menopause within 10 years, and don't have contraindications. The risk benefit is probably favorable in terms of taking hormones. It lowers all-cause mortality while you're taking a medication that's helpful. And so basically, we need not to be so afraid of some of the risks of menopause, but it is very important for each patient to have that conversation. There is potentially an increased risk in using hormone therapy, but certainly it's a wonderful therapy, and it can help. It does provide some long-term health benefits, specifically all-cause mortality, and decreased risk of osteoporosis and diabetes, and it's actually not dangerous to take it for your heart too. So these were my myths, or the things that we talked about today. So ovarian hormones play a very vital role in women's overall health and well-being. Perimenopause is definitely a window of vulnerability and opportunity for women. We should manage those symptoms with lifestyle changes and medications. Hormone therapy is safe and is effective for women in that first decade of menopause, provided they don't have very specific risk factors. Women with premature menopause under 40 and probably under 45, to be honest, should really think about going on hormone therapy for long-term health benefits. There appears to be a favorable cardiovascular profile for hormone therapy users, but there is still some increased risk of breast cancer. Estrogen alone hormone therapy, definitely you have many more of the advantages and fewer of the disadvantages. So if you have had a hysterectomy, you can use estrogen-only hormone therapy, and that has many more benefits. And vaginal estrogen alone should be used for whoever needs it and be liberally handed out. So that's my talk. I understand a few questions.
Thank you, Dr. Bierfest. So we do have myself and Shay who are going around with some mics. If anybody has questions for Dr. Bierfest, just let us know.
One over here. I'm just going to grab my water.
Hi. So I'm about 1065.
So you're not too late. If you didn't need it in those earlier years, then that's the. So if you've safely made it through, navigated that first decade, and you're not having horrible symptoms, I would definitely not recommend you start it, because that would be in the older age group where there was really a higher risk of heart disease and breast cancer and stroke and pulmonary embolism. So it's not a good thing to start after that first decade of menopause. Vaginal estrogen, you can start at any age. But no, presumably you've done other things to keep yourself healthy, and I don't think you should feel like you missed out or you didn't do the right thing by your health at all. There's a question.
If they've ever done studies using E3 instead of E2 in menopause.
So E3 is not considered a very potent estrogen, and it doesn't really help very well with hot flashes, and it also doesn't really have any of the strong effects that estradiol has. This is one of those bioidentical compounded formulations where they often combine different forms of estrogen, E1, E2, E3. So estradiol is the one where it really has the therapeutic benefit. They are never, ever going to repeat the Women's Health Initiative. That was far too expensive. And again, it wasn't even done with estradiol, which is what we use these days. It was done with Premarin. So, but it's probably not harmful, but probably not therapeutic.
I was thinking, since it wasn't as strong as E2 that we make naturally during menstruation years, that maybe it would cause less of the risks.
Yeah, I think it has less of the risks. That's fair to say.
Hi. Someone that was forced into menopause early due to cancer. So I started in around 44. So now I've been on for 10 years already. And I had to go off for a little bit. And I still, when I went off, I still have symptoms. So how long do you suggest someone in their 40s to start? Do you still suggest that 10 years, or is it okay to go a little longer?
I usually, if a patient's had premature menopause or gone into menopause surgically because their ovaries were removed, usually recommend treating with hormone replacement therapy to at least the average age of menopause, 51. And then at that time, if they're doing well, the medicine's working well, then you're the same as all the other women who are going through menopause at the more normal time. So then there's the pros and the cons of continuing on the hormone therapy, all that I just went through, cardiovascular health, bone health, but an increased risk of breast cancer. So that increased risk of breast cancer probably doesn't apply for if you start hormones early, because by virtue of losing your estrogen early, you've lowered your breast cancer risk. So then if you take estrogen, you've sort of got it back to baseline again. Hi, Amy.
Is there a risk in taking hormone therapy if you have been diagnosed with a clotting issue, like a factor V or a factor V latent?
Generally, it would not be prescribed. Factor V Leiden, you can be homozygous or heterozygous, whether you've had a clot or not. You might be able to have some wiggle if you've never had a clot and you're heterozygous. We would use a patch rather than the pill, because the patch has much less clotting risks because it doesn't go through the liver, so it doesn't ramp up. Yeah, but I think if you've had a blood clot, it is a contraindication.
Has there been any studies or discussion on the brain fog issue? It seems to be like this thing that everybody, glazes over in terms of menopause. And then some people say, oh, it's not brain fog, you're depressed. It's like not depressed, but I just wondered if there were studies about that or discussions about the drugs and
Yeah.
figuring that
So
out.
we don't really know quite what contributes to brain fog. It could be some part of depression. A lot of it could well be related to sleep disruption. I think that's the number one thing I focus on, is like trying to make sure patients getting a good night's sleep. I didn't put that on the slide, but I mean, one of the things I know I was really interested in, like hormone therapy, does it help your brain? Do you not get dementia if you take hormone therapy? Unfortunately, it doesn't look good for dementia. In the Women's Health Initiative, they did have a separate arm, and the older women who were on hormone therapy had more dementia, more Alzheimer's. They did do some studies over the phone with the younger group, and they at least didn't show it got worse. But I don't think estrogen really is going to be the answer for brain function. But there definitely are patients who, when they're not on hormones, they don't feel right, they don't function right, and then feel so much better and so much more themselves. So I think brain fog is a hard, I think you just have to sort of try it and see if it helps. Of course, knowing all the risks and benefits.
So one of the things that we did last year for the first time that seemed to be very successful was that we brought some of our nurse practitioners to help close the gap between we're hopefully informing you and giving you some great information, but how do you actually action on it? And so as a result of last year's panel, we had a number of people, hopefully a lot of them in this audience, that were so thrilled to be able to identify and engage with a nurse practitioner. And what's been really wonderful over this last year is we're having these nurse practitioners that are continuing to invest in their education and specialties, and so they're offering even more capability to us as a year-round and seasonal population. So we are going to bring up to the stage Carey, Dr. York Best. We're going to be doing our panel with a number of folks. Tiffany Blake Lamb is going to be our moderator, and she, as I mentioned before, completed her OBGYN residency training at Mass General Brigham Women's Health in 2012, and she actually studied with Dr. York Best. She became a full OBGYN physician at MGH shortly after that. In 2016, she started covering occasional weeks and weekends for obstetrics at Nantucket Cottage Hospital, and she gradually increased her time commitment to NCH over time. So what's really exciting for us is for the past 5 years, Dr. Blake Lamb has spent 75% of her work time here at NCH, and then she's been able to also devote 50% of her time to gynecology. She's now living on island with her husband and 2 small children, and she continues to work 1 week a month at Mass General. So she's really still staying very much connected to that level of specialty care. For example, people like Dr. York Best and being able to help with referrals, but she's here. She's going to be moderating our panel with 2 nurse practitioners. We've got Nancy Lucchini, who is an NP at Nantucket Cottage Hospital, who focuses on women's health and children's health. And in the area of women's health, she does a lot of work along the lines of OBGYN. And she has been doing this for 30 years. So this is a woman who has a tremendous amount of experience and expertise. She and her husband have raised their 4 children, 2 boys and 2 girls. And one of them was actually born on Nantucket, is not one of the few island natives that hopefully will go into healthcare. We also are delighted to have Ashley Beliveau, who's a fairly new member to the Nantucket Cottage Hospital. She holds a bachelor's of master's in science from Johns Hopkins. She and her husband were sort of longtime frequent flyers here at NCH, and last October she joined Nantucket Cottage Hospital, and we're so delighted. And they are raising their 1-year-old here, and what a great place to get started. So please welcome to the stage Dr. York Best, Tiffany Blake Lamb, Ashley Beliveau, and Nancy Lucchini. Thank you.
Thank you, Lisa, for that wonderful introduction. And thank you to our sponsors for the event today and to everyone for coming out on this beautiful Nantucket summer day. And I also want to take the chance to say thank you to Dr. York Best for a very wonderful presentation. I have been learning from her for 16 years, and today is no exception. So I thought we could just start by having our nurse practitioner colleagues tell us a little bit about what they do to care for women. So first of all, can you guys tell the audience what proportion of your primary care population is women that you care for?
I would say at least half, maybe more than half. I do a lot of the family practice, and I also have dedicated dermatology days. On those dermatology days, I do usually see more women in general, and the men that I do see are forced to come by their wives. So.
I probably see about 50% women during my day. Some of it is family med. The other part is taking care of our pregnant moms.
Very good. So from a primary care standpoint, what types of health issues are important for you to cover with women who you're seeing in the perimenopause or menopausal years that might be new or different than what you might have covered with them when they were premenopausal?
Specifically in the perimenopausal and then the menopausal years, I do tend to see a lot of rosacea. I also tend to see women who have acne that have never had acne before. So those two issues are probably the biggest ones, specifically relating to our topic. Other things that we talk about during our visits, specifically in dermatology, are skin dryness, fine lines that start to creep up, and just the aging process in general that we can all talk about.
As women approach menopause, we start worrying about their heart health, their exercise. Everybody complains about the weight gain, and how can we keep women healthy as they approach their menopause years, and what do we do to help them with the changing periods, because as Dr. Pasterk was saying, they get crazy, and how do we care for women with their the birth control issues, because as long as you're having periods, there's always that chance that you can still get pregnant. So a lot of care on how do we make the best of that time and help with this is getting convoluted, sorry. So, but help them with their heart issues and their perimenopausal bleeding, mood disorders, weight gain.
And then Ashley, I'll follow up on something you mentioned, because a lot of women that I see when they go through the menopausal transition will talk about their skin just feeling excessively dry. Do you have any tips or tricks that I could learn from?
I do. So regarding the full body, of course, keeping moisturized, I tend to tell patients to stay away from lotions and optimize towards creams. Lotions tend to just stay on that surface level of the skin, whereas creams do get absorbed better. And after a shower is the best time to moisturize. Regarding the face, there's all these fun types of topicals that we could try. One brand new one that is getting big in the dermatology world is estriol, which is a derivative of estrogen, specifically for the face, can help with collagen production, dryness, elasticity, all the fun things. So there's combinations of those two. Hyaluronic acid can be added in that topical for excessive dryness. So there's definitely more options becoming available.
Sounds great. I'd like to find out how to prescribe that. So then switching gears a little bit to when you're seeing women in your offices who are either going through perimenopause, having a lot of the symptoms that Dr. York Best spoke about, or they're in menopause, and you feel like they need a little bit more specialty care than what primary care can provide. Can you tell us a little bit about what types of specialists you refer to for women during this time frame? Gynecology being the obvious one.
Gynecology always. And it's nice having Dr. Blakely just down the hall. But also urology for women who start suffering urge incontinence, stress incontinence.
Pelvic floor therapy is another really beneficial referral too.
So I'd like to actually direct one question towards Dr. York Best. So it's not an uncommon thing that I have women come to my office who say to me, you know, I think I'm going through perimenopause, or am I in menopause? Am I not? I read online that I should have all of my hormones checked. What do you tell that patient?
I hearken back to the roller coaster, and I say you can't really test in perimenopause because it's, you know, we're going to get one test on one day. It could say you're in full-blown menopause. It could say you're, you know, completely premenopausal. So it's really a clinical diagnosis, you know, the right age, the right symptoms to make a diagnosis of menopause. So I don't find it helpful except in a few situations. Someone's got a progesterone releasing IUD. They never have any periods. We really can't figure out, they're not really having symptoms, but we can't figure out if they're in menopause or not. Sometimes that will be helpful, but I try to stay away from it in the perimenopausal time. I do a thyroid quite often though, because thyroid is one disease that can have very many overlapping symptoms with menopause, and that's pretty easy to treat.
I agree. That's all I had. So any other questions from the audience for our panelists?
What do y'all recommend to help people sleep?
Yep. Well, I think as Dr. York Best alluded to, I think the primary thing we think about are the night sweats, the hot flashes that happen during the sleep. Is that what's keeping you awake? And if it is, then we can talk about different modalities of treatment, hormone therapy being one of those. But we have non-hormonal alternatives as well to really dampen down that hot flash trigger during the night, help you get to sleep easier, stay asleep, and be able to fall asleep again if you wake up. And I've had many, many women who just say that they can't remember having slept as well since before they had children. Once they can, you know, we can use these therapies to help get a good night's sleep, and then helps everything else during the day. You know, if you've gotten a good night's sleep, your brain functions better, you're in a better mood, everything.
Is there anything over the counter y'all recommend?
If somebody's looking for a non-prescription, I usually recommend Benadryl. It's a non-habit forming medication. Doesn't always work for everyone. Some people get the reverse effect, but that's a minority of the population. And you just have to titrate the dose, because what's on the bottle might be too strong. You might just need a half of a dose to sleep well at night, but not feel groggy the next day.
I think melatonin can be helpful too. Some patients do respond quite well to that. Both of them can have a bit of a hangover effect if you take them too late at night. So not a good thing to take up if you woke up at 1 o'clock in the morning and trying to get back to sleep, because then you're going to feel really groggy and run down in the morning.
So Beth, I take 25 milligrams of diphenhydramine every single night.
Yes.
And I think
Which diphenhydramine is Benadryl.
is Benadryl, right?
You have come over to my house.
That works great for me. I take it every night. I've taken it for probably over 12 years. Are there any long-term?
Yeah. Not that I'm aware of, and I think that they would probably be offset by the benefits of getting good sleep for 12 years. Yeah. And I will mention also that diphenhydramine is available at over the counter at Stop and Shop, also as a liquid form, marketed under ZQuil. And so it's not NyQuil that has Tylenol in it, but it's just the diphenhydramine, the ZQuil. It's liquid form. So I personally use it to titrate if it's late at night and I just want a little dose versus I finally got my kids to bed and it's 8 o'clock and I want 10 hours of sleep, a bigger dose. Yeah. Go. Yeah. Yeah. One of the main ones that Dr. York-Best mentioned in her presentation is gabapentin. It's a medication that can reduce hot flashes in that sort of moderate category, not as much as hormone therapy, but better than placebo. But it has a side effect of being sedating. So we tend to, whereas when gabapentin is used for other medical indications, it might be used throughout the day and night. In this way, we use it for women. Just take it at night so that they get the benefits of the reduction in the hot flashes, but also the benefit of feeling sleepy.
What about thank you. And what about non-prescriptions or herbal, such as magnesium?
I don't know any data specifically on magnesium, but I kind of feel like it's probably not going to be harmful. And so if you as an individual find that it's helpful, I think go for it.
As one of your patients that's been dealing with this for 20 something years, what are the risks that you would, describe specifically for women over 60 or 65?
Well, I think that the data that Dr. York-Best presented at the very end of the study is something that is brand new in the field, where the researchers have gone back to the Women's Health Initiative that initially scared everyone into not using hormones. And now we've looked at the data in a new way. So we know that women who are 60 and older are in those higher risk categories for a lot of the outcomes that Dr. York-Best spoke about. But that's where I think it comes into an individual conversation in the office about you as an individual. What is your family history of breast cancer? What is your risk of osteoporosis? What is your individual cardiac risk score? And where do the risks and benefits balance out for you as an individual? Okay. Oh, sorry.
So I get the pleasure, sorry, I'm loud. I get the pleasure of thanking everyone for coming today, and thanking Janine and Meryl and Melanie for putting this on set for 7 years now, for Lisa and Heather for being the hosts this time, and for all of our amazing speakers, many of whom all of them I am so incredibly proud of. Nantucket Cottage Hospital, we are community health, and part of our mission is to educate. So sessions like this are so incredibly helpful. And I was watching faces and just watching people, absorb that information, but meeting some of our amazing resources that we have. We are so lucky, and it's because of the support of everyone here. So thank you. Thank our sponsors. Thank everyone here today. And I get the best part of saying that we're going to meet outside on the lawn for reception and questions. Thank you.